Okay, let's see who's here. 9. My daughter went to school today. Today was the second day. She actually had in-person school for the first time in forever. So I'm tracking her on my cell phone. I can see where she is on the bus. I'm being a stalking mom. I think just like last time, the quiz doesn't actually open till 1, but right at 1, you guys can start it whenever you come in and open it up. But I don't think it actually will open for another 2.5 minutes.
Hey, Leslie.
Yeah.
I'm sure that we've talked about this, so I apologize. On Moodle, you have it set up a certain way, right? Because like with the grades, like is it different? Because like even if you've like turned everything in and you've gotten like did well on it, it seems like my grade is very low. So I don't know if it's just because like we haven't like done everything yet. Does that make sense?
It could be. Let me just kind of.
If it makes you feel any better, Megan, I have done everything and it shows I have a 15% in the class, but I think it's just because it's not, it is saying like all the points are added up, but I only have like 50% or so
of the point.
Yeah.
Yeah, like, it just looks really weird. And I was like, well, I've done everything and done okay. And it still says I'm barely passing. I'm like,
yeah. So at this point, I'd have to do some quick math. At this point, I'm not sure how many points we're at, but you can say, so there's been however many study notes that are 3 points. The first and second are, so the 6, 9, 12, 15 points for the study notes. 50 points for the exam. So that's 65, 85. And then the quizzes, 85. Oh, shoot, I just lost my place. 85 plus 40. So that's 125 points possible. I could be wrong with my math, but I think we're at like 125 possible points. So then if you look at how many you have, no, we got to have more than 125 points.
I mean, it's not important right now. I just wanted to ask about it. Like, we don't have to waste time talking about it, but.
Yeah, I definitely think you're totally fine. It's probably just the way it's showing up. I mean, I can see that you have lots of points. So,
Yeah.
and I think I was off by saying 125 because you have more than that. So we must have more. So yeah, if it's looking funny on your end, it's just Moodle. You're fine.
Okay, thanks.
And then you guys can all start the quiz.
Leslie, do you mind muting yourself?
Yes, I'm so sorry.
No, you're good.
Leslie, did you get my message?
Who was that? Who just talked to me?
Megan.
Hold on. You guys can do the extra credit one on your own time. I think that one is open longer. I can't remember. But you don't have to do the extra credit one now. You can do it later today or whenever.
It just said 10 minutes and I accidentally clicked on it. So it's not going to like, it'll still let me do it, right?
I'll go in and make sure that you guys can take it more than once. If you have a problem retaking the extra credit one because you started it on accident, I'll just adjust it so you guys can just take it again.
Oh, okay. Thank you.
Mm-hmm. Okay, it looks like you're all done. Okay. So does anybody have any questions on that quiz that you just took?
Leslie, did you is the extra credit one like open note, or you can just take it as many times as you want?
Yeah, it should be. I'm not positive. After we get done with class, I'll go back in. But what happened was I wrote a quiz and then I realized there was already one in the course because I bring stuff over from the previous year. And I wrote a quiz on that content and there was already one there. And I was like, oh, there's 2 quizzes now on whatever. And then I thought, well, I'll just make 1 extra credit. So that way it kind of gives you guys a cushion. Like if somebody bombs a quiz, I dropped the lowest one. So that's always in there, it's the lowest quiz gets dropped anyway. So that kind of gives you that cushion if you miss one without an excuse or that kind of thing. But then it gives you even a little bit extra in case, you whatever, it just, you don't do well on one, it gives you a little cushion grade wise. But you guys should be able to, it's open book, however you want to do it, it's totally fine. And it should have more leniency with the time. And I'll go back in and just make sure that it's open for long enough time. I probably shouldn't put a time limit on it. If there is a time limit, I'll take it off.
Leslie, I have a question from the
Yeah.
quiz. I don't know if it's the same order for everyone, but the last one on the quiz where it says if a patient is suffering from persistent mild asthma, what's the drug we assume they take?
Let me see. Hold on just a sec. For you, it was the last question.
Yeah.
Your patient reports having mild persistent asthma on their medical history, but did not note any medication. What prescription might they be taking for this condition? Mild persistent.
Isn't albuterol always the first drug of choice for asthma?
I think it's because what might be a little bit tricky is that it's the mild persistent. So they're probably on a continuous, like a daily one. And I think albuterol is your rescue inhaler. So that's for just for every once in a while. But singular is that kind of controlling one. And so since this is something more has, it's
Something
more,
you take on a daily basis.
exactly.
Okay.
So that's why it's singular over albuterol.
Okay.
Yeah. I think that was the key, was the mild persistent part. Okay. All right. Let me pull up the PowerPoint here. And I put a recording of the prescription writing because I wasn't sure if I was going to get to that or not today. And then when I was reviewing this yesterday, I try and sort of time myself to see about how long it would take. And it seemed like maybe I was going to get through this faster than I thought. So instead of going all through, we'll kind of skim the if I do have extra time, we'll kind of skim the prescriptive writing PowerPoint, and then I have like some group work. We'll do some like breakout room work. So we'll just see where we end up, how much time we have in the end. Okay, so no, that's not what I wanted. Yes, it is, I guess. Okay. Okay, so antibiotics and antifungals, I don't know if you guys realized or noticed, at first I was a little thrown off since I haven't gone through this coursework yet. I was like, where's the antivirals? Aren't we supposed to talk about acyclovir and things like that? But I think it looks like we talk about that in maybe next week or in a couple weeks when we talk about HIV. So we'll go back to this chapter in weeks coming, kind of like how we went back to chapter 1 and just read over a couple pages for the prescription writing. So we're just doing antibiotics and antifungals for this week, in case anybody else was kind of confused about that. And then, so here are the objectives, and these are the antibiotics that you're going to want to be familiar with, the ones that are in red. Those are the ones, because there's other antibiotics, but those are the ones that might show up on a quiz or an exam. So those are the ones that you want to be familiar with. So this slide shows us how it shows the kind of the chain of infection and how everything's sort of connected. And then it shows us the areas where you can break that chain of infection. So we kind of are really familiar with this now with all of the COVID, with the hand washing and the social distancing. And of course, we think a lot about means of transmission, how our virus is transmitted. We think about aerosols. I mean, all of this is so ingrained in our heads now that this is not an unfamiliar slide or topic at all. You know, susceptible hosts, ports of entry, but then we can see, we kind of want to focus on how do you disrupt those? Well, it could be with treatment or medication. It can be with something as simple as just hand washing or disinfecting an area, things like that. That's how you can break that chain of infection. Here we have some terminology that we'll want to be familiar with. Antibiotics, they are a chemical substance produced by microorganisms that can destroy or suppress the growth of another organism. Antibiotics typically are kind of natural in that way. They like grow antibiotics, but they also do create synthetic antibiotics. And some antibiotics are like 100% synthetic. So they're not even like a real true antibiotic, but we still sort of call them that. If they're destroying or suppressing the growth of another organism, then we sort of still put them under the same umbrella term of antibiotics. We want to be really familiar with bactericidal and bacteriostatic and know the difference. Bactericidal is, think of that, the cidal portion of that word is like killing. And then static, you kind of think about like frozen. They can't replicate. They're kind of frozen from doing what they want to do to replicate. So it inhibits their growth if they're static. So bactericidal, bacteriostatic, and then resistance is the ability of an organism to resist the effects of an anti-infective agent. So we get concerned with antibiotic resistance. MRSA is an antibiotic or is a bacteria that's very resistant to certain a lot of antibiotics because of overuse. And so it's mutated and it's become more resistant. So we want to think about that when we use antibiotics and how we use antibiotics. Superinfection is when antibiotics disturb the normal microbes in our body and we get out of balance, and then another infection might take over, like yeast is like the most easy example to think of. And that's our natural flora is out of balance, and then something overgrows and kind of takes over in the population. It's the same way in the mouth. We have all these bacteria in our mouth that cause gingivitis, but if everything's kind of harmonious and in balance, then we don't get gingivitis or periodontal disease. But it's when those bacteria grow out of control and the balance is off is when we see the disease. When bacteria take over, so when are antibiotics necessary? Basically, we need to utilize antibiotics when the bacteria is sort of taking over and our immune system isn't able to kind of get a handle on it. So when bacteria take over or there's an imbalance, we need antibiotics to attack and kill the bacteria. And then that gives our immune system the chance to get rid of the infection and then start the healing process. Antibiotics for dental use, there's pretty much three main reasons that we would use antibiotics in the dental office. The first one would be like if somebody has an infection, we think of, like a perio abscess or an endodontic abscess. We call them the treatment of odontogenic or oral facial infections. That's sort of the umbrella term to encapsulate all of those different infections that might happen in the mouth. And then prophylaxis against infective endocarditis. We don't call it bacterial endocarditis because we know that there are viruses and fungi and bacteria involved in the infective endocarditis. So that's why it's called IE. And then we also may prescribe prophylaxis antibiotic to patients who are immune compromised and at higher risk of having an infection. So sometimes it's not just because of the risk to their valve or an infective endocarditis, but it's just in general, they're at much higher risk because of something like immunocompromised. So what were the first antibiotics? So in 1928, Alexander Fleming sort of accidentally discovered penicillin, but we can't say that he was the first to use antibiotics. Many people in history used various substances, but they didn't always know, they weren't calling it an antibiotic. They didn't know that it was that something on that substance was killing bacteria. They didn't know things were getting better. They just didn't know why. But Alexander Fleming, he sort of was, I guess, a little bit messy of a scientist, and he left the lid off of a petri dish that was growing some bacteria, and he noticed that a fungus, Penicillium notatum, I'm sure I'm saying that wrong, notatum, I don't know, I'm not a microbiologist. It had contaminated the petri dish or the culture, and anywhere where that fungus was growing, which was the penicillin, anywhere where that fungus was growing, there was no bacteria. And then he just noticed that even when he diluted it to like 800 times the dilution, it still killed the bacteria, and it caused far less negative outcomes than whatever they were using at the time. So that was sort of hailed as like the first, like miracle drug in that category because of just its ability to kill bacteria and was relatively safe. And I guess the culture on the plate was Staphylococcus. So that was the first bacteria that they noticed that penicillin was killing, was the Staphylococcus. Okay, so what's the goal of the antibiotic? So ideally, we'd be very selective, because we don't want to just wipe out, we're teeming with bacteria, really. I mean, we're like practically, half bacteria, really. And so we don't want to just wipe out bacteria out of our bodies because they help us with so many aspects of life. So ideally we'd be very selective, but that can't always happen. So in general, we want to try and kill the bacteria and then hopefully maintain as much homeostasis. But that is why we get these adverse reactions, like a lot of GI issues, a lot of gut issues from taking antibiotics, is because a lot of time we do end up disrupting that balance when we take an antibiotic. So antibiotics versus antiseptics. So pretty much antibiotics tend to be more selective in general. I mean, we'll do like anaerobic versus aerobic, or, you know, gram positive, gram negative, these kind of things. Whereas an antiseptic is not selective at all and just like wipes out everything, just kills everything. So that's a difference between, you know, what we're trying to go for with one or the other. So what we're looking for when we look to use an antibiotic in the most effective way, we're looking to create a chemical that targets the bacteria in a very specific way. And we look to target those things on a bacteria or a virus or a fungi that is very different from a human cell, so that when we take the antibiotic, we're not hurting the human at all, or at least hopefully not very much, but we're affecting the bacteria. So the way we do that is we look for differences. So humans have cell membranes, bacteria have cell walls. So we look for those there's different ribosomes. Bacteria have different ribosomes than human cells. There's different DNA. Bacteria have different DNA than human cells. So we look for those differences, and then we kind of target those. And so the antibiotics kind of focus on those things that are unique to the bacteria that they're trying to kill, or reduce its ability to multiply. So the terms that we'll just kind of keep focusing back on are bacteriostatic, bactericidal. Those are the two terms that we kind of think a lot. Static, preventing it from multiplying, kind of disrupting its ability to make more of itself, and cidal, like killing the actual bacteria. So weakens, disables, and stops growth of bacteria, kills. That's the difference there. So does it matter? This is a link you can, it's a short article, but it's kind of nice because it summarizes it very well. Some antibiotics start out at lower doses as being bactericidal or bacteriostatic, but then at higher doses, they become bactericidal. So they're not always cookie cutter, like this is only this or this is only that. Sometimes it's dose related. So there's different ways that antibiotics damage a bacterium's cell in order to kill it or eradicate it, through the cell wall destruction, inhibiting its protein synthesis, or getting to its DNA. So those are like the three main things. It can either, if it messes with the cell wall, then, you know, the insides are all susceptible. If it can get to the, and if it can prevent it from replicating, then it's kind of going to die out, or it's not going to cause damage. Or if you get to its DNA, then it's definitely going to kill it. So those are its three mains. However, it's not as cut and dry as that. For example, penicillin can be bactericidal at high doses, but it can also be bacteriostatic. So sometimes, like I just said in the previous slide, sometimes it's dose related. And another example would be vancomycin is cidal against staph and strep, but it's static against enterococci. So then it might depend on the kind of bacteria that it's targeting. It might be bactericidal toward specific bacteria, and then others, it doesn't kill it, it just prevents it from replicating. And then azithromycin is another example. It's cidal against strep, but it's static against staph. And so the main point of that resource that was on this other slide here, this, if you click on that and read it, kind of the take home points from that article is that antibiotics can be bacteriostatic for some pathogens or bactericidal for others. And clinical outcomes depend on the variety of factors and the properties. So, and it kind of doesn't even matter as long as clinically you're getting the end result. Like as long as clinically you're helping the patient recover from whatever bacteria is causing them to become ill. It's like, who cares if it's cytal or static? We just want the patient healthy, right? Okay, so types of bacteria. So bacteria has distinguishing characteristics, and some of this you guys will remember from microbiology. So there's the shape, there's bacilli versus cocci, there's nutrient and preferences for either oxygen or no oxygen, or they can live in both, or, you know, there's that variation. But then the one that kind of stands out the most is that gram-negative, gram-positive. So for gram-positive, they have this very thick outer lipid membrane, and then just this one little peptidoglycan layer. So it doesn't absorb that violet stain as much. And then gram-negative has all this peptidoglycan layer, so it holds on to that violet stain really, really well. So that's a very distinguishing physical characteristic that you can see different from the different types of bacteria, gram-positive, gram-negative.
I thought if it was gram-positive, it held on to the stain, and that's why it's positive.
It's kind of funny, isn't it? Like there must be a reason, like a way to think about it. Cause I was thinking that too it's literally been like 2.5 decades since I took microbiology, but I was like, negative. I would have thought it's negative. It doesn't hold on to the stain, but that's not what any of the literature.
I read, because we have a test in Perio today about gram-negative and gram-positive. Gram-negative stain red and gram-positive stain purple.
Yeah, the difference between, so I got two different, I have this picture. So this kind of seems to show the opposite. And then the differences between gram-positive and gram-negative allows gram-negative to hold the violet stain while gram-positive does not. So we're contradicting Perio. And you're telling me we're contradicting Perio?
Yeah, so if it's gram-positive, positive means it holds the stain. If it's negative, that means it doesn't hold the stain. So that's why it doesn't come out purple.
Somebody look it up. Look it up, because I can't. I'm on my sharing.
She's right. That's how I remembered it. Positive equals purple.
And gram-positive has the thicker peptidoglycan, I think, not the gram-negative.
Is this picture wrong too?
Yeah, I think so, because we've learned that gram-positive have a thick cell wall, and that's why it can hold on to the stain.
I think the picture is wrong. It's like mixed up.
That's so funny, you guys. Okay.
It's right here, Leslie.
Are you all are finding it?
Yeah, it's right here.
You can even Google it, and yeah, it comes up as.
Oh my gosh.
It says gram-positive dense cell wall, stain purple on crystal violet dye, gram-negative.
It's so funny because when I was looking over this, I was like, I remembered it differently in microbiology, but I just kind of accepted that this was true because this was what was on the slide. Okay. Oh, you guys are so smart. What would I do without you?
Wait, then I think the picture is showing that the purple dye is within the cell walls. So the picture then would be correct, wouldn't it? Because it's showing that the dye is in the cell wall, and that's why it's holding the purple. And then in the gram-negative, it's showing the
exact
purple
same graphic, but they're labeled opposite.
You have the thicker peptidoglycan though.
So are they saying because this has the outer membrane, it holds the stain?
I think that's what it's trying to say.
Whereas this doesn't have the peptid layer, so the stain doesn't hold as well, and that's why it stains pink.
Yeah.
Oh, that makes sense.
Well, Tasha's right. There's definitely a thicker peptidoglycan layer on the gram-positive cells.
So then this might be.
No, this is the same graphic, but they're labeled wrong on yours.
Yeah.
Oh, okay. So
If
okay.
you So I think the labels just need to be switched, but the graphic is like correct, but they need to be relabeled.
So let me say this, and then you guys tell me if I've said it right. So this over here is gram negative. This side is gram negative, and it's not going to hold a stain as well. And then this is gram positive, and this is going to hold the stain.
Yeah.
I see a shaking head. Okay. Okay. So I'll edit the slide. Thank you guys.
Yeah, the way I think of it is if it's gram positive, the person that made the stain was named gram, so that means it's holding the stain.
Yeah, and that
But if
makes
it's
sense.
not, then it's negative.
Yeah, that totally makes sense because you think too, it's positive, it's holding the stain. The stain is there, it's positive. Oh, that makes so much more sense. And that's how I thought I remembered it. Okay, yay! Okay, I'm gonna make a note. Slide 13. Okay. All right, moving on. We'll fix that guy. Okay, so now what actually ends up killing the bacteria? So penicillin and cephalosporin, they both have something called a beta-lactam ring. And that beta-lactam ring, it basically goes in, beta-lactam antibiotics work by destroying the bacterial cell wall. So this is one of the antibiotics that actually ruptures the wall, weakening the cell, and then the inside of the cell is all susceptible to outside forces. And so it's actually targeting the cell wall. And that's the same for both penicillin and cephalosporin. They both have this B-lactam ring. And this pretty much says the same thing. So B-lactam antibiotics, they kill the bacteria that are surrounded by the cell wall. And then the bacteria cell wall is all sort of, when the bacteria comes together, and this is another thing, I had to look this part up because I was getting the cell wall confused with like a biofilm, because we know that bacteria come together in a biofilm and they kind of work together to strengthen themselves within that biofilm. But this is different than the biofilm. This is the actual independent cell wall. Of course, the bacteria, when they all come together in a conglomerate, they get this, the biofilm makes it even harder to penetrate. The antibiotics are harder to penetrate, but this is actually referring to just the individual cell walls. That was my understanding. If anyone read it differently, but I was starting to think like, is that referring to the biofilm or is it the actual cell wall of the bacteria? So, so the internal parts of the bacteria become vulnerable to the outside environment, and then the cell ruptures and then it dies. So since amoxicillin is sensitive to breakdown by an enzyme called B-lactamase, they can add something called clavonic acid. And that's this last category here, which is amoxicillin and then clavulanate. And that makes augmentin. I don't know if anybody has ever heard of that before, but sometimes when they write out a prescription, they just say augmentin. So that's for certain bacteria that have this B-lactamase, which makes penicillin and amoxicillin not quite as effective at rupturing the cell wall. So if they have some, a certain bacteria that's more resistant to it, then they'll prescribe augmentin.
My son had to be put on augmentin when he had like his chronic ear infections. And oh my God, I had to leave work so many times because he would get it and then he would just throw it up.
Oh, it was really hard on his tummy.
Yeah, it was so terrible.
Oh, that's awful.
And they were like, he's sick. And I was like, no, he's just on a really strong antibiotic. Does he really come home? And they're like, yeah.
Oh, complicated infection. So there you go. So penicillin is narrow spectrum. So some of our basic things like strep throat, pneumonia, ear infections that are clearing up easily, obviously not ones that are not clearing up. Amoxicillin is a little bit broader than penicillin, good for tonsillitis, pharyngitis, endocarditis. We use that's our kind of go-to for our pre-med. And then odontogenic infections. And then augmentin is like a stronger one, basically, like Megan was saying, stronger, more complicated infections.
Leslie, I have a quick question.
Yeah.
With the amoxicillin, with odontogenic infections, if someone's allergic to amoxicillin and they come in with an infection, obviously we can't give them amoxicillin. So what are some other examples of antibiotics that they might be prescribed?
Clindamycin is a really common one, and that one they would probably be able to take if they can't take amoxicillin.
I remember that now that you say that. I could not think of it though. Okay, thank you.
That's a common. There's other ones too, but that's a common one. I don't know why the penicillin goes away. I can't remember why that goes away. I think there's, and this is red. So there's obviously a question that was connected to this, and I don't know it's like disappearing. It's all just disappearing. I'm not sure why. Okay. So issues with penicillin. So drug interactions, we know already that there's several antibiotics that can decrease the effectiveness of oral contraceptives. So we've counseled our patients on using an alternative birth control. Possible decreased efficacy with tetracycline. So if someone happens to be taking both antibiotics, they would take them at different times a day. Increased toxicity with methotrexate. Methotrexate is a strict anaerobic antibacterial. And then increases effects of warfarin. Does anybody remember what warfarin is?
It's a blood thinner.
Yeah, it's a blood thinner. So a lot of antibiotics affect warfarin. So that's important for you guys to remember. Common adverse drug reactions, a rash, very common, GI upset, augmentin, more so than amoxicillin more so than penicillin. And then yeast infections as well. And then contraindications, allergy, of course, sometimes is like, well, of course, that's a contraindication, and you'll see that a lot. Usually the major contraindications for antibiotics would be allergies. And then the writing is right over what this says. Oh, I have it up here. And then, of course, if they have a severe allergy to the cephalosporin, those are cousins. And so if a patient has a severe allergy to one or the other, sometimes they won't prescribe the other. So if they have a severe penicillin, then they might not do cephalosporin and vice versa. Keflexin or Keflex. Common uses, bacterial endocarditis. For our patients, this is an alternative to amoxicillin. However, if there's allergies, they won't use it. They'll go to clindamycin. Skin, soft tissue infections, urinary tract infections. Drug interaction may increase the effects of warfarin. Rash, GI, and yeast. I kind of think of it, I know it says nausea, vomiting, diarrhea, but I kind of just go GI upset. So rash, GI upset, and yeast infections. Anaphylaxis with cephalosporin. If they have had a severe allergic reaction, such as anaphylaxis to cephalosporin, then you wouldn't prescribe Keflex. And then use caution with the penicillin. So that's, a lot of times they'll just go right out of that category and they'll just go to something else when the doctor's prescribing. I lost my mouse, there it is. So cross allergenicity, so between the penicillins and the cephalosporins, there's a 10% cross hypersensitivity reaction. So if it's mild, like they just got a rash, they may still use it. They say it's okay to use cousin antibiotics, but if it's severe, then they don't use anything with that beta-lactam ring, because obviously that must be what triggers the allergy. I lost my word. Okay, so endocarditis prophylaxis. So our standard. The standard protocol is, or the standard regimen is amoxicillin. That's the one, 2 grams or 4 tabs of 500 milligrams of amoxicillin taken 1 hour prior to the dental appointment. That's sort of the standard. And then if patients are allergic to penicillin with varying degrees, then these are the other ones that would be considered. Clindamycin, 600 milligrams, cephalexin or azithromycin. So which medication could be used if a patient has a history of anaphylaxis when taking a cephalosporin? So which one would you not use if they had anaphylaxis to cephalosporin?
Cephalexin.
Mm-hmm. Yeah. So you would not use cephalexin, you'd use either clindamycin or azithromycin. I've never seen them prescribe azithromycin. I've only seen clindamycin, but I'm sure it just depends on the doctor. But as expanded practice hygienists, since we can write this prescription, we should know what's the most common and what's safe. So clindamycin seems to be kind of a standard. But that's nice to know that there are other options. If someone says, oh, I can't take clindamycin, and it's like, okay, well then we'll try azithromycin. So patients who need pre-medication. So this was the slide that was in the deck to begin with. When I first went through it, this was the slide, and it's much simpler. So I left it in there because it reads much simpler. It just puts it down to 3 categories: patients with artificial heart valves, patients with a history of infective endocarditis, patients with serious congenital heart defects. And then here's a resource that you can go and check that out. But I put this one in here because this was the most recent from the ADA, and it just goes into a little bit more detail. But I highlighted, you can see that the common denominator here is valves, valve, or a history of infective endocarditis. So it gives a little bit more detail: prosthetic cardiac valve, prosthetic material used for cardiac valve repair, the following congenital. So this was where the congenital portion comes in, just like this down here is congenital. This is where the congenital portion: unrepaired cyanotic congenital heart disease, including palliative shunts and conduits, or any repaired congenital heart defect with residual shunts or valvular regurgitation. So it's kind of like things are there's still something there. It's a congenital issue, and there's still something in the heart that is being monitored and maybe still has a residual issue. So those are the times that you would use pre-medication. So that just had a little bit more detail. And then as far as joints, we're getting farther and farther away from pre-medicating for joints. But I liked this. This was just published in 2020, and it's a decision tree. And I just really liked it because it made it very simple. And this is in combination with the ADA and Academy of Orthopedic Surgeons. So that's who came up with this decision tree. So this is implant patient. So joint replacement patient, someone who has a joint replacement with planned dental work. Yes, well, okay, yes. So then you come up here, invasive dental, or the next one is invasive dental procedure, yes or no. Invasive would be pretty much anything that's going to manipulate the gingival tissue. So yeah, we're going to do a cleaning. So yes, we go up to here. Severely immunocompromised, yes or no. Most of your patients are not going to be severely immunocompromised. So then you would go down to no. And then a history of an infection requiring operation. So have they had, so you're down here at the no, I lost my mouse. You're down here at the no, and they say, no, I did have an infection around my joint. So then you go up to yes, and that is maybe appropriate. Call their doctor, talk to them about it. They may say, yeah, just put them on a pre-med. Or no, I've never had an infection around my joint, rarely appropriate. You can still call their orthopedic surgeon. The patient may still tell you, no, my doctor said I have to take a pre-med. So there's still going to be those doctors out there that just want to do it, but they're getting farther and farther away from it. But this gives you a good just sort of decision tree of how important is it, and you can talk with your patient. And it also said in this paper, it said that, I have it written up here somewhere, hold on. The dental practitioner should use his or her own best judgment when deciding to use antibiotic prophylaxis, and to always consider the patient's opinion regarding this issue. So they don't, if they absolutely don't want to, if they're down in this realm of not necessary, then they have the right to be like, no, I'm not going to take the antibiotic. But you can always consult with their doctor and tell them that they should consult with their doctor. It's always safer to err on that side of things, but I just like this decision tree. Okay, so moving on, macrolids. These are antibiotics that are considered static, not cytal. So we have protein synthesis inhibitors. So they're going to inhibit the replication of the bacteria. So we have macrolids, Lyncomycins, and Tetracyclines. And then these are the subcategories. Erythromycin and azithromycin are macrolids. Clindamycin is a Lyncomycins, and then tetracycline, doxycycline, and minocycline are tetracyclines. So the macrolids inhibit protein synthesis. Specifically, they bind to the 50S ribosomal subunit, whatever that means. That's the specifics of it, but it inhibits the replication, and they're bacterial static. Common uses are for upper respiratory tract infection, bronchitis, pneumonia, sinusitis, acne, uncomplicated skin infections, STDs, chlamydia, and then mycobacterial infections such as tuberculosis. Erythromycin and azithromycin are the ones under that category, under the macrolids, like we said. And then azithromycin can be used when the person is allergic to penicillin. So that's another good one to know. That's why azithromycin was one of the ones, azithromycin and clindamycin was one of the ones that you can prescribe. Azithromycin is most effective against gram-positive bacteria and some gram-negative. There are many drug interactions with azithromycin, though. There's less so with azithromycin. Erythromycin has more drug interactions than azithromycin. These drugs can inhibit drug metabolism in the liver, increasing blood levels of other drugs that the patient might be taking. Antacids can decrease the levels of macrolids, so the patient has to be aware if they're taking an antacid. So adverse reactions would be those GI upset, rash, and then cardiac arrhythmias is something to be aware of in this group. Allergies to this group would be a contraindication. They're contraindicated with certain drugs. That's the responsibility of obviously the doctor to not prescribe it. But I think the book said, I didn't write it down. Just wondering if I can find it really quick here. Oh, a statin drug, simvastatin. They decrease the metabolism, resulting in increased blood level. So yeah, so those are some heart dilantins. So basically that's a seizure drug, phenytoid, dilantin. Zocor, which is simvastatin. So I guess it is important to know, I mean, the biggest reason, a lot of times we think, well, I'm not prescribing it. The doctor's going to prescribe it. But you can prescribe it for a patient if you have your EPDH and you're prescribing it as a pre-medication for someone who has a valvular issue or previous endocarditis. So that is important to know those specific drug interactions. And I'm getting that out of the textbook, so you can go back and make extra notes by this drug out of the textbook. Okay, and then caution with patients who have myasthenias gravis. That's an autoimmune, it says muscular disease, but it's sort of a neuron muscular it's like the connections that, we'll talk about it in special needs, but it's a communication area in the neurons that affect the muscles overall. And so caution with patients who have myasthenias gravis. Okay, so lincomycin or clindamycin or cliacin That's the other static, bacteriostatic in this group. So common uses would be bacterial endocarditis prophylaxis for patients pre-med, skin infections, bone infections, and then anaerobic bacterial infections. Patients could be on this for periodontal abscesses or periodontal disease. Very few drug interactions with clindamycin, but there are some pretty significant GI drug reactions, diarrhea and abdominal pain, the Clostridium difficile diarrhea. It can kind of wipe out a lot of the good bacteria in the gut, causing that diarrhea. And then rash, yeast infections, which we see with almost all antibiotics. Contraindications would be an allergy, or if they've had a history of the pseudomembranous colitis, then that would be, or ulcerative colitis, then that would be a contraindication if they have had a history of that in the past. Okay, tetracyclines. What time is it? Let's see. Well, we're almost, let's do, hold on, let me just jump ahead real quick and see. Okay, I'm gonna go through the tetracyclines and then we'll take a break. Okay, so tetracyclines is another bacteriostatic, inhibits the protein synthesis with the, but this time instead of the 50S subunit, it binds to the 30S subunit of the ribosome. Tetracyclines can be used in skin infections such as acne or MRSA, the methicillin resistant Staphylococcus aureus. I'm trying to remember, I had MRSA one time on my arm, and I'm trying to remember what they gave me, and I thought it was Flagyl, but I don't think it was tetracycline. I don't think it was clindamycin. But they did a test to specifically see what mine was effective, like what would kill it. And I think that's why I got Flagyl for the MRSA. But anyways, respiratory infections, they use tetracycline for respiratory infections, pneumonia, bronchitis, Lyme disease, or chlamydia. And I think I already said it, but is this one cytal or static? Is this bactericidal or bacteriostatic?
It's static.
Mm-hmm. And that inhibits protein synthesis, sort of gives it away. Good job. Okay, so some drug interactions, major mineral interactions. People who are taking a tetracycline should not swallow it with a calcium pill or a magnesium pill. Aluminum and iron, they have to be careful. And then warfarin is another, just like the other ones, it can increase the blood levels of warfarin. GI upset, photosensitivity for this one. So patients who are taking tetracycline have to be careful how about sun exposure they get, rash and yeast infection, and contraindication, allergy to tetracycline. And then the cardinal one that will stick out in your brains forevermore is absolutely never give tetracycline to somebody who's pregnant or to a child who's still developing their dentition, because it will it'll bind to certain, oh shoot, I had it written down and it's not in here. It binds to certain parts. Oh, it's in the book here. Anyways, it binds to calcium orthophosphate. It binds to in the teeth, and it deposits this yellow to gray sort of striping, and it's there forever. So that is, and you don't see it too much in the US because we sort of hopefully know this. Most doctors wouldn't prescribe this to pregnant women or young children, but sometimes maybe in other countries where they might not be as aware of this, or it's maybe tetracycline is what they have available to treat certain deadly things, then they might give it. And then that's when you'd see that stain. So I've seen it in older generations, but I have not seen it in younger generations because we kind of are more aware of it now.
Hey, Leslie, quick question.
Yeah.
I knew that, so I take magnesium, and so when I did LexiComp, for that. You know, it said to take tetracyclines 1 hour before. Anyway, I looked up iron before and I didn't see any interactions. Is it like a type of iron or something like that?
I don't know. That's a good question. I'd have to look it up. I just kind of went by what was in here as one of them. So that's a really good question. It might be there are different types of iron. So it could be that certain chemical mixes of, of iron are actually more problematic than others.
Okay.
I'll have to look it up. That's a good question. Iron and tetracycline. Okay.
Mostly, I have a quick question about the contraindications with pregnancy. Is
Mhm.
that when like the pregnancy is in a certain period, like in a certain term or like a number of weeks specifically? Or is that why like it's important to ask, like, is there even a possibility that you could be pregnant? Because it doesn't matter when they're at their pregnancy, it could still affect it.
Yeah, and the hard part is the fetus, it's like within a couple, like tooth buds start forming very early, like super early. And you guys will probably remember it better than me from whatever course with Katie. But it's so when a woman is pregnant, like 4 weeks or 6 weeks, it could happen. But I think doctors are so aware of this that if they're looking at a woman of childbearing age, they would ask about that. Any chance you're pregnant, any chance that you're going to get pregnant, and they'd veer to an antibiotic that wouldn't cause this. At least in America, I think that would be the tendency, because throughout the whole pregnancy, the baby's teeth are developing. So you would never want to use it through the whole pregnancy. Your dog is so cute. Okay. Within tetracycline, there are some special preparations that we use, and Periostat is a really interesting, because Periostat is actually not considered an antibiotic because of how low of a dose it is. It's 20 milligrams of doxycycline, and it's too low to be considered. I think it's milligrams, or is it micrograms? It could be micro. I don't know. And so it's, well, it says mg. So I think mg is milligrams. But it's such a low dose that it doesn't act as an antibacterial in our bodies, or an antibiotic in our bodies. It acts against as a collagenase. So it acts more like an enzyme attacking what in our body is breaking down the collagen, our PDL and all the supporting structure around our periodontium. It helps to inhibit that breakdown process. So that's how it acts, not like an antibiotic, which is fascinating to me. And so Periostat is actually a pill. And then we have Atrodox, which is a solution that is mixed chair side and then put down into the pocket. So it flows into all the morphology, the root morphology and everything, all the little gaps and indentations, it flows in there, and then it sets up kind of like a wax. And then then it slowly dissolves, and so you get that localized antibiotic. And probably collagenase activity as well. And then Arrestin uses minocycline, these tiny little beads. They're microspheres of minocycline. And again, it looks like a powder, but they're these little spheres. And you push it down into the pocket. And then once it hits the cervicular fluid, it solidifies, and then it slowly dissolves over like 10 days to 2 weeks. So these are localized. So there's not a lot of systemic absorption happening. Obviously doxycycline, there's some systemic, but with the Atrodox or the Arrestin, there's not a lot of systemic absorption. They still are contraindicated if someone has an anaphylactic reaction to tetracycline, but in general, there's not a lot of worry about that.
These are all dental, right?
Mm-hmm. Yeah, these are just specified in dentistry. Okay. So let's take a break from there, because I think that's the last. We'll do the quinolones. There's a couple more antibiotics. So let's do a break. It's 2:06.
Hey, Leslie.
Yeah.
Trey asked a quick question in the chat about Periostat and how long you would have it prescribed.
Yeah. Oh man, I just watched over the summer. I watched a really good CE. Oh, how often? How long do they? I'm gonna stop sharing for a second because I had a really good resource that I was looking up about that. I may have to answer that question after the break. Let me see how long people usually stay on Periostat. Go ahead and take your break and then I'll find the answer and I'll let you guys know when we come back. So it's 2:06. So let's do like 10 minutes. So it's 2:07. So let's come back at 2:15. Let's just round it. We'll do 2:15.
Leslie, can I ask you a question?
Yeah.
So I have my advising meeting with you tomorrow at 11:30. Are we going to do it over Zoom or in person?
What is tomorrow? Wednesday. I'm home tomorrow. So tomorrow is over Zoom.
Okay. Are you just going to send me the Zoom link?
Yes. And
okay.
And is this Emily?
Yeah.
Yes. Okay. I didn't have my thing up, so.
You're good. Thank you.
You're welcome.
Leslie, I know you're looking at that thing, but I was going to show you how my dog was sitting on my lap.
Oh, let me see.
She's literally like on my lap right here, and she was like sitting with her paws like on the desk, just like sitting like this so I could like pet her.
Like, I'm learning pharmacology.
Yeah, like I'm listening to you, Mom.
You're like, remember this for me so I don't have to.
Yeah, exactly.
What's her name?
That one's Coco. I rescued her a couple years ago.
Oh,
yeah.
We want to get a dog this summer. I said I have to have a chunk of time when I can be home to like let like potty train and make sure everybody's getting along. So we have a very moody cat, and so I want to make sure that everyone's copacetic. And then Lola is probably going to want to like pull and scream at the animal, so I want to make sure that everyone gets along. So I think probably right at the end of the semester, we'll start seriously looking for a puppy.
Yeah. Oh, so fun. Yeah. I love them. They are kind of a lot of work. It's funny, like when I first got Coco, I was like, oh, like what's a second dog gonna do? Like, because both my dogs are literally weighed like 10 pounds.
Mm-hmm.
So I was like, what is a second dog gonna do? Like, it can't be that hard, but it's actually like so much more work for, and like, because she's part poodle, she has to be groomed like every 2 months. And like more often in the summer because like she doesn't shed, so she doesn't lose her fur. And then like she gets mats, so like I have to brush her and like I have to bathe her in between because she smells really bad. Like it's just, and the Chihuahua, like I had a Chihuahua before that, like just him, and he's like, you take him in every now and then, gets his nails clipped, and like he's fine. So I do love that she doesn't shed, but like I just did not think about how much, like it's so much work to maintain her like coat and everything. So
that's actually really good to hear that, because there's Olivia's kitty.
A little kitty. Yeah.
Because I was thinking of getting like a Labradoodle.
Yeah.
And my grandparents always, and all my uncles and grandparents had poodles. So that side of the family has always loved poodles. So I was like, oh, maybe we'll get a Labradoodle. Yeah. But I know that there's that grooming aspect.
Leslie. You should talk to Tasia. Look, she has a Labradoodle. Yeah.
Labradoodle. Aren't they the biggest loves? Like, is Tasia, is that just a big lump of love?
Yes, and he doesn't shed, and he's always lying around everywhere. Look at it.
Yeah, look at that. Oh.
They're so cute. They're like just big teddy bears.
Yeah. I mean, honestly, like I would love to get a Labradoodle, like, but living in an apartment, it's just hard for me to get a bigger dog. But I love Labradoodles or Golden Doodles. But Yeah, just be aware. Like I'm sure Tasia can report to this, like the grooming aspect. And you really have to do it. Like Coco wasn't groomed properly by her previous owner, so she would be sedated every single time to get groomed. So like you really have to start with them as a puppy, because she's terrified. Even now, she is terrified of the groomers. And it's like it's been such a process. Yeah.
He's good.
Is he? Yeah. Did you start with him as a puppy?
Like I groom him most of the time.
Oh yeah.
Good. He's just
brush him.
We don't brush him as much. That's something we should do more often. But since we had a kid, we don't have time. Yeah, but
that's fair.
He's usually like, he becomes a statue the minute we start doing anything to him. He doesn't move at all. So I usually cut around his face so he can see, because most of the times the doodle's like covered up.
Yeah.
Yeah, but I would say they're like the best dogs in the world. Like they don't shed, and this guy just plays around in the house all.
And they're so happy.
Getting a Labradoodle. Get a Labradoodle.
Is Tasia, is your dog a Labradoodle or is it a poodle?
He's a Labradoodle.
He's a Labradoodle.
Yeah.
Did you get it from a breeder?
Yeah, we got him from a breeder.
I have a friend, a hygienist friend, who knows a breeder in Estacada.
Mm-hmm. We got him from Oregon City, but the breeder stopped doing it now. But, the good thing is he has more poodle in it. So even though like we don't take him for too many walks because of Oregon's weather, he doesn't gain weight. That's another good thing with the regular Labradors. I think weight gain is like one of the, like you need to take them on walks.
Yeah. You do see a lot more with, that's true. Like when I see labs out there, if they're not real active, they do tend to get a little bit round. That's true.
The good thing about poodle mixes is they don't gain weight easy.
Yeah.
Different Coco eats so much food, like so much. She's always eating food, and she hasn't like gained weight the whole time I've had her.
That's so funny. That's interesting. I didn't know that.
And she's not like unhealthy. Like the vet's like, she looks fine, you know, so, but she eats so much food.
There's so many dogs different breeds that I like. That's so hard. I keep going back to Labradoodles, but I really like Weimaraners. I think they're so beautiful, but my husband, like, they're so high strung and just, but they're so, I love the silvery, I love that silver fur.
Yeah.
You know, it's so beautiful.
I recently fell in love with Bernese Mountain Dogs. And they kind of look like St. Bernards, but they're not quite as big. They're still pretty big, but they're not quite as big as a St. Bernard, but they kind of have like the markings a little bit. But yeah, they're pretty like high strung, high energy, and they have really long fur that sheds.
Yeah.
So, but they're so cute.
There's so many beautiful. We had a pit bull, which is always stereotypical, you know, like pit bulls have a bad rap, but she was my absolute baby. And she had short fur, like short, you know, and so I'm telling you, like 5 years after she passed away, I'm like, there's Izzy fur. Like it was everywhere all the time.
Oh my gosh. Yeah. That's going to be me with my Chihuahua. It's just his furs and everything. Like, I don't know how I even get it out of stuff. So
it's like little needles, like everywhere.
Yeah, absolutely. Yeah. Well, I'm excited to hear if you do get a dog in the summer. That'd be cool.
Yeah, you guys will find out after. Yeah, which one my daughter keeps saying, you always say we're going to get a dog and then we never do. Because I chicken out because life is so busy. Yeah. And I'm like, I have a 2.5-year-old. How am I going to have a puppy? So I do chicken out, but I do want one. I think we need it. We need a dog. So hopefully the right one falls in our lap. We'll see.
Yeah. Yeah.
Okay. Let me go back so I did find out, is everybody back? I found out Periostat is given twice a day, and they say up to 9 months. So they say to separate it in 12-hour doses, twice a day, every 12 hours, so morning and night, basically, and then for up to 9 months. And I think if they're not seeing any kind of improvement in the perio condition, then that's probably when they stop treatment. So you don't just take it forever and ever. It has to be doing something, positive. Let me get my slide back in the right place here.
Olivia, thank you for showing us the pug.
Did I miss the pug?
I just had to point it out so everyone could see the dog. You're so cute.
Now oh, I missed it again. It's okay. I think I saw your pug before, Olivia. I'm just always, anytime I see an animal in the screen, I'm like,
I have a beta fish.
oh, I love betas.
I have son every day that we leave the house, he goes, bye, fishy.
Yes. We had a beta and we named him Hush. And he lived for about 4 years, I think. Okay. It always goes back to the beginning. Sorry, I gotta. Okay. So quinolones are not, so this is one of those antibiotics that they're not technically an antibiotic because it's totally synthetic, but they still consider it a broad spectrum. They still refer to it as a broad spectrum antimicrobial, and it works, so that's all that really matters. But so quinolones would be ciprofloxacin, levofloxacin, and moxifloxacin, and they're used for urinary tract infections, upper respiratory infections, pneumonia, and chronic periodontitis. So I'm trying to remember, I think Cipro is one that I have seen doctors use before. I'm not so sure that I remember levofloxacin or moxifloxacin, but that's just my personal experience. I have seen when I was working for the periodontist, he would write prescription for ciprofloxacin, but not very commonly. So some doctors are very against just prescribing an antibiotic for periodontal disease. It depends very much on the person's response to all the other things like the scaling and the root planing, if they're seeing a periodontist, and if they're having periosurgery, and how their oral hygiene is, like all these things are taken into consideration. So for the other name for the quinolones is the fluoroquinolones. So they are bactericidal. They interfere with the DNA. So that's, I think so far this is the only one that we've reached in this category. So that's something to remember, that they interfere with the DNA. They also have a photosensitivity or phototoxicity, so patients have to be very careful of sun exposure, dizziness, headache, cartilage damage with our drug reactions. And then again, we see the warfarin. This one also, there's an interaction with dairy, iron, antacids, and caffeine for the quinolones. And then flagell is the other one that interferes with the DNA. So metronidazole. This is the one that can't be taken, if we remember from way back. Was it amoxicillin? I'm going to have to scan all the way back to remind myself. Now I can't find it. There was one that the drug interaction was with this. Hold on. Yeah, with penicillin. So increased toxicity of a methotrexate. Well, now I feel like I'm just getting myself and everybody all confused. Oh, this isn't the same one. Okay, just completely ignore me. I was thinking of something else. Okay, so flagell is the is the brand name for this. So common uses, anaerobic infection. So that can be another reason why it'll be for more serious infections, necrotizing gingivitis, periimplantitis infection as well. They might prescribe flagell. H. pylori, which is the one that causes ulcers, and then protozoa infections, which are parasites. So Flagyl is pretty strong, so they can use for a lot of these different more serious infections. And then this is the one that you want to remember for the alcoholic beverages. Even like something as simple as a mouthwash can cause this interaction. And even several days after somebody has taken metronidazole, they don't want to consume alcohol for up to 3 days because it causes this reaction, this kind of nausea, headache, dizziness. It can also cause a metallic taste in the tongue or a furring of the tongue, get that furry coating on the tongue, and then peripheral neuropathy as well. Contraindications would be an allergy, and then pregnancy in the first trimester. So this has to have caution if within the first trimester. And then I have no idea what strong caution with ETOH. I was looking in the textbook. Does anybody enlighten us with this, ETOH? I'm like, this must be something very obvious that I am just missing. But I read through the text like 3 times, and I was like, I looked up ETOH, but nothing came up. Does anybody have anything? I was gonna delete it, but it's already on your PDF, so I just left it there, but I might delete it for.
Is it ethyl alcohol? I'm so bad at chemistry, but I remember something about the alcohols.
Do you think it's connected with the alcohol? I mean, that would make sense.
I think Trey said ethyl alcohol.
Okay, maybe that's what it is. I was so stumped. I'm like, maybe someone in the class will know. So I'll do a little more research with maybe if I just had Googled metronidazole and ETOH, maybe it would have come up, but I was quite stumped there. So I have no idea what that's, but maybe maybe it's the alcohol. That's a good.
Yeah, I think it's just ethanol.
Ethyl something or other.
Ethanol. Yeah.
Oh, okay. Yeah, that makes sense. Okay, good.
And like anything in alcohol or even like mouth rinse or, things like that can have ethanol in it.
Oh, makes perfect sense. Okay, awesome. So our conclusion with antibiotics, there's lots of different classes, different target sites, different bugs, gram positive, gram negative, staph, or, oh my gosh, anyways, never mind. And then if it's inhibiting it or if it's killing it. And so we also just want to make sure that we're always using them wisely. We use them when we actually need them. We don't use them when we have a virus and, instead of a bacterial infection. We want to make sure that it's appropriate so that we don't overuse them, create a resistance, and because we want to have them for future generations. We want these antibiotics to work. Remember, they always say you want to use really the most minimum or the most, you want to try and do the antibiotic that is almost the simplest form before you go to these stronger and broader spectrums, because so you want to use, and if we use them too much and create a resistance, we won't be able to use the simplest one. We'll have to go to something more complex and broader spectrum to get the same result, which ultimately is really not good for us. So we have to be careful with our prescribing of antibiotics, which that's become, obviously more in our awareness in the last couple decades. So that's good. So this slide just shows there's antibiotics on here that you don't need to know, but it's just kind of a neat slide because it shows how it affects, if it affects the cell wall, if it affects the DNA, if it affects the ribosomes. It just shows it in a nice, for those visual learners, there's your ribosomes with the 30S and the 50S subunit. So it shows how it affects, which ones. So that's just good for some information on how it's destroying the bacteria. And then this is just for you guys to fill out. These are put in those major points that you want to know for quizzes or exams, just to help you remember those common uses, adverse effects, and contraindications, just off of the PowerPoint slides. And then if we go over antifungals, so fungal infections are caused by molds and yeasts, and so an example of that would be Candida is a fungal, but is a fungi that's in our system, or a yeast that's in our system already. So it's not like it's horrible bad. It's just that if it gets out of balance and it grows out of control. So antibiotics can lead to these super infections like we talked about earlier, because they kind of mess with the balance of everything. They wipe out the good bacteria that helps to keep us in balance. So the antibiotic may knock the flora out of balance, reducing natural immunity to fungal overgrowth. Then patients who are immunocompromised, they also have to deal with this just anyways, even if they're not taking antibiotics, they're just immune compromised and they're more susceptible to this being out of balance. So if your immune system isn't working good, then that's what can lead to something like thrush, which is what this picture is showing. So with the antifungals, we have azoles. I don't know if I'm saying that right. And then we have the Polyonus. And under the azoles, we have the Myconazole or Monostat. That's one, a lot of people are familiar with the name Monostat, or the Clotrimazole, or the Mysilex. And then the Polyonus is the Nystatin, is something that you'll hear very often for when patients come in and they either have oral thrush or they have angular cheilitis. Sometimes the doctor will prescribe them Nystatin or Mycostatin. So if we look back at this, just to remind ourselves, these two, Monostat and Mysilex, these are static. They are going to inhibit the growth. So they're going to block the ergosterol, I should always pronounce these 10,000 times before I go into our lecture. I say it in my head, but I don't always say it out loud. Ergosterol, probably saying that wrong, synthesis. So they are a static. And then the Nystatin binds to the ergosterol in the cell membrane, and it causes, again, that rupturing of the cell wall, which leads to death. So one is static, one is cytal. So Myconazole and Clotrimazole, they are used for oral, so thrush or vaginal candidas, fungal infections, like possibly even like fungal infections in the toenails, those kind of things, or on the skin. And then the drug interactions with those, again, you can see how warfarin plays in even with the antifungals. Warfarin is just like, they must all bind on the same receptors or something, or there's something, but that's going to increase the blood levels of warfarin, and cyclosporin as well. There's an interaction with cyclosporin. And then adverse reactions, minimal systemic absorption, because you're not usually swallowing a pill. Sometimes you are, like with Diflucan, which is like a stronger systemic antifungal, but a lot of these are topical applications or an oral rinse. There are some rinses though, like for thrush, where you rinse with it and then you swallow it. So there is some systemic. So I don't want you to think that there's no systemic, but it's sometimes less so depending on if it's a topical application. And then contraindication would of course be an allergy. So if they've reported an allergy to it, then that's contraindicated. Nystatin, again, common uses, oral or cutaneous fungal infections. There's not a lot of drug interactions with Nystatin, so that's nice. Adverse reactions could be nausea, vomiting, diarrhea, local irritation, and if there's an allergy, you wouldn't use it. And then here's just, and I added Diflucan because you can get some of that information out of your textbook, but I just think that that's a drug that you may see on a medical history of somebody may take it, especially, you know, you could see it for someone who's immunocompromised or who has some kind of a systemic fungal histoplasmosis or something like that. So I just thought I would put that in there. You're not going to be tested on it, but I just thought that's a common antifungal. So I just thought that that should be added to the list. And you can get some more information, even though it's not in the PowerPoint, you can find it in the text. Okay, so that's the last one there. Any questions with the antifungal? Oh, somebody, so is ETOH like the chemical write out like of ethanol basically? Is that what we decided? Yay, awesome. Okay, so I'm gonna stop sharing that, and we have about 15 minutes. So what I would like to do is, and I feel like I have to give you guys just a little bit of, because I could either just go through the PowerPoint, which I feel is sort of redundant and boring, or I'm just gonna pull this up really quickly and show you. So there's this PowerPoint is in Moodle under this week's topic. And so if you, when I put you guys into groups, if you guys pull this up and one of you could share it, and if you go through, there's just a few slides. The first couple slides talk about basically what we can prescribe as hygienists. You don't really need to study that, right? You don't need that for this exercise. The next one shows the parts of a prescription. And again, for this exercise, all you really need to focus on is the body of the prescription. And again, it gives you a little bit more detail about what's in the heading, what's in the body, what's in the closing. So that's just, this is your heading, you have the patient name, doctor's name. In the body, you have the medication, the dosage, how you dispensed it, and then the instructions for them to take it. And then the closing is going to talk about refills. And then you have, and I go into a little bit more detail on the recorded lecture. That it's only like an 8-minute lecture, so please listen to it. But I'll talk about the DEA number and what's it for. These are classes, schedules of drugs. They're all controlled substances. That's why they're under schedules. Do we have a DEA number? No, we don't, but we do have an NPI number. I talk a little bit more about that in the lecture. So, but you don't need any of that for this exercise that I want you guys to do. We should be very familiar with the Latin abbreviations. You don't ever have to use a Latin abbreviation. If you forget, if you know that the patient needs to take it 1 time a day by mouth, write 1 time a day by mouth. But there are Latin abbreviations where, like, just for example, let's just pull up twice a day, BID, twice a day, PO, by mouth. So that's the abbreviation, but you don't have to use that. You can literally write out twice a day by mouth, every 12 hours, every 8 hours, whatever it is. But these are, you will be quizzed on these. So for future reference, you'll want to go through and you'll want to know that PM is for the afternoon, AM is for the morning. That's kind of, you know, we know that already, right? And then you'll just kind of go over those a little bit more. But you don't, again, for this exercise, you don't have to have those. So I'm trying to get to the meat of it here. This is an example of a fluoride prescription that is written out. It's sodium fluoride. It's 120 tabs. Chew and dissolve 1 tablet in the mouth, then swallow once per day, preferably before bedtime after brushing. So that's an example of a prescription that's written out. So now we can see here, this is what you will need for the exercise. This, you want to know the age of your patient. Are they 6 months to 3 years? And then you need to know how much fluoride are they exposed to? Are they on well water and there's no fluoride at all, but they're under 3 years old? Then you're going to write the prescription for 0.25 milligrams of fluoride, and then they'll take the tablet once a day, chew it, preferably before bedtime. If they're between 3 and 6, you're going to either do this or that, depending on how much fluoride is in their drinking water at home. So obviously you guys aren't going to necessarily know that just from a case study. You would talk to mom or dad and say, how much fluoride's in your water? And they'd say, we're on a well, we have no fluoride, or we need to get our well water checked because maybe they have natural fluoride in their water. So this slide will be useful for the exercise. Here's another example of a fluoride topical gel that they either brush on or put in trays. Here's another example of, these are all just the body of the prescription. It's just the body part. This is another example of antimicrobial rinse for chlorhexidine. This is an example of a pre-medication, a prescription for pre-medication. I think dispense 5 is a typo. I think it would only say 4 because you just take 4 of them to get 2 grams of amoxicillin. So I think that's a typo. So I say that in the recording, but I just wanted to clear that up. Here's another one. This one is for someone who's allergic to penicillin. So they're going to use clindamycin. So now let's practice. So what I have here is, I'm going to put you guys into breakout rooms. Did anybody have any questions? I thought I saw the chat. Something happened in the chat. So I'm going to put something, I'm going to stop sharing. And I am going to put something in the chat here. Hold on. Okay. Here is a Google Doc for everybody to go to. So you guys will be in groups of like 4 or 5, and there's 2 cases. So you're going to write a prescription for a 6-year-old boy for fluoride, and then an adult for a pre-med. So, and then this Google Doc, you'll see, it'll say like group 1, group 2, and I'm just going to put you in like sporadically. So just take note of which group you're in and just write under that heading. So if you're in group 3, right under the group 3, and just write out the body. You don't need the heading or the closing, just write out the body, what you would prescribe. And so cross fingers that this works. Do you all feel good about it? I'm going to put you into breakout rooms, assign automatically, and I'm going to do 7 breakout rooms. So someone's going to have 4 or 5, I can't remember. And then open all rooms. Okay. So just make note if you're in room 1, 2, 3, 4, and then write your answers under there.